Hello everyone, welcome to this tutorial on the use of lung ultrasound in patients with COVID-19. And my tutorial will focus on introducing you to the principles of lung ultrasound. What are the normal artifacts and the normal findings when you scan the patients? And what are the advantages of lung ultrasound, the requirements to do lung ultrasound study, and the different important protocols that were found useful in scanning patients. And we will end by focusing on the use of lung ultrasound in patients with COVID-19, whether for the diagnosis, monitoring, and assisting our management of these patients. So historically, in Dr. Harrison's textbook of internal medicine, it was said in the 1990s that the lung is not suitable for ultrasound. And unfortunately, or actually fortunately, this has proved to be wrong. And around the same time, Daniel Lichtenstein published his seminal paper on the use of lung ultrasound in intensive care unit. And since the 1970s, when you do a simple search on PubMed, quoting lung ultrasound as your key search word, you will see the exponential increase in the number of studies, which includes the utilization of lung ultrasound to evaluate several pulmonary conditions. So the principle of using ultrasound is based on the idea that ultrasound is not transmitted through aerated tissue, the normal parenchyma is not visible, the interface between the pleura and the lung is the interface which reflects the ultrasound, and our acoustic window is the intercostal space. So the advantages of lung ultrasound are quite plenty, especially it's quite immediately available at the bedside, repeatable and reproducible, and it provides a rapid goal-directed application at the point of care, and especially in emergency situations. It reduces cost by reduces the need for chest x-rays, and also it provides a way to reduce radiation exposure, and especially in our COVID-19 cohort of patients, if we utilize lung ultrasound, we might reduce the need to transfer the patient to the CT scanner, which reduces cost and also reduces the incidence of infection and cross-infection by moving the patient outside of their bed space. So what do we need to have to provide or perform lung ultrasound? We need to know which probe we are going to utilize. So we have two types of probes. We have the low frequency transducer, which is the cardiac phased array transducer here at the top of the screen. And we have the other low frequency transducer, which is the curvilinear or convex probe. Both can be used effectively when scanning the lung, when you are focusing on the lung parenchyma. And I kind of prefer the cardiac probe for several reasons. I prefer it because it has a smaller footprint. It fits easily in the intercostal space. I also prefer it because I usually perform lung ultrasound as part of my transthoracic echocardiography study. So for me to have a kind of integrated approach when I do my examination. And I also feel that sometimes the phased array transducer might give me a little bit of a better resolution, but we know that such low frequency transducers have deeper penetration on the expense of reduced resolution. On the other hand, when we utilize the high frequency probe, this is especially important when you want to scan the pleura. So when you do your lung ultrasound, you want to aim at two things in the lungs. You want to aim at scanning the parenchyma by low frequency probes and scanning the pleura by high definition, high frequency transducer, which has a poor penetration but high resolution, which is especially useful, as we will discuss very shortly, when you diagnose or rule out pneumothorax, and when you also want to diagnose non-cardiogenic pulmonary edema and pneumonia by looking at the pleura itself. So the next thing, now we identified which probes we need to use. Now let's look at the different zones of the lung that we need to scan. So we have standard 6 zones on each lung, 6 zones on the right lung, and 6 zones on the left. And as you can see in these images, we have the zones separated or divided or determined by a horizontal imaginary line across the nipple line, and we have the parasternal line anteriorly, anterior axillary line, posterior axillary line, and the most posterior imaginary line is the paravertebral line. And this will divide you into 2 anterior, 2 lateral, and 2 posterior zones. It might be a bit challenging in the intensive care to scan the posterior zones because patients might be, or usually are supine, but I would always recommend to go as far as you can laterally or try to get to the posterior segments, because this is where the devil is usually hiding. You need to get into the most posterior aspect of the lung to detect specifically areas of consolidation. So we now learned the type of the probe, we learned the zones of the lungs. Let's move to where we put our probe when we scan. So the first thing is to know your question. Am I looking for pneumothorax, or am I looking for evidence of interstitial edema due to heart failure, or am I looking into pleural effusion? If I'm looking into pneumothorax, I need to scan with I need to scan at the non-dependent zones of the lung. So if the patient is supine, you need to scan apically at the lungs. And this is just a fake 3D printed probe. And I'll just show you for demonstration on myself. When you have a pneumothorax, you will utilize the high frequency probe, the linear probe, the one we use for line insertion. And with this probe, I put it in the mid-clavicular line, second intercostal space, with the indicator of the probe directed to the patient's head. This is my initial starting position, and we will see very shortly what we expect to see. But if I'm scanning for heart failure and trying to get into evidence of interstitial edema, I need to get into more dependent zones. And here I will use the low frequency probe, whether it's the cardiac probe, the phased array, or the curvilinear probe. While on the other hand, if I'm scanning to get pleural effusion, I have to go into the costophrenic angles on both sides. As you can see here in the picture, you will put your indicator toward the patient's head and you will put your probe in the mid-axillary line. This is where you will get the diaphragm as your landmark, and the liver below the diaphragm on the right side, the spleen below the diaphragm on the left, and you will look to what is above the diaphragm to see if there is any evidence of pleural effusion or consolidation or atelectasis. So let's go into the different artifacts in the lung and try to analyze what are they. The first thing is, what is normal? So once I start, as I said earlier, with the high frequency probe, the linear probe, second intercostal space, mid-clavicular line, with the indicator to the patient's head, the first thing I will see is the 2 rib shadows here on both sides and the pleural line in between. It's very important to start vertically to get the rib shadows, because these will be your landmark to avoid mistaking the pleural line for any other lines of the chest wall, as you will see here. And this will give you what has been described as the bat sign. So the pleural line and the upper and lower ribs make a permanent landmark. And you can see here a mirror-shaped artifact of the pleural line. They happen at equal distance from each other. These are called A-lines, as we will discuss very shortly. And they always reflect normal aeration of the lung, and they can also happen if there is pneumothorax. So once I get the bat sign, now I don't need to keep my probe vertical anymore. I can rotate my probe 90 degrees. Either way, it doesn't matter clockwise or anti-clockwise. So I can align my pleura with the ultrasound beam, and then I will look into the shimmering movement of both layers of the pleura together, which is described as, or known as, the lung sliding. Why this is lung sliding important? Because this sliding rules out the presence of pneumothorax. So again, the sliding, as we can see here, is the movement or the shimmering sliding of both layers of the pleura, the visceral and parietal pleura, with every breath. And the sliding, for the sliding to happen, you need to have adequate ventilation, adequate tidal volume, and you also need to have healthy layers of the pleura. This leads us into understanding the causes of absence of sliding. If you have air between the visceral and parietal pleura, you will not see sliding, you will lose it. And if you have an extensive pleural fibrosis and adhesions, you will also see the sliding. If you have no ventilation of the lungs, there is no ventilation, no tidal volume of the lungs, you will also not be able to see sliding. So when I see the sliding on 2D, I put my M-mode cursor to confirm that there is no pneumothorax. And the confirmation by identifying what is described as waves on a sandy beach, or the seashore sign. So what is the seashore sign? If I see the sliding and put an M mode, this is the picture that tells me that there is no pneumothorax. So it tells me that the chest wall is represented by the waves. This very bright line here is the pleural line, which is represented as the breakers. And finally, the parenchyma, or the lung parenchyma itself, this very heterogeneous structure here, is represented by the sand. This is very important and very typical. So the sand, or the heterogeneous part of the lung, is important to rule out pneumothorax. And back to the normal artifact, we just mentioned about the A lines, but when I use the low frequency probe, as we saw earlier, you will see the depth of the screen and the reverberation mirror-shaped artifacts of the pleural line together. And again, this is a typical of aeration of the lung. And it can happen if there's a pneumothorax. And as a reminder, I would remember A lines as the presence of air, whether it's normal air or abnormal air, if there is a pneumothorax. But it commonly refers to normal aeration of the lungs, meaning if the lung loses aeration, in case of hydrostatic pulmonary edema or non-cardiogenic pulmonary edema, you will start to lose the A lines. The other normal finding that you could see commonly in normal lung is the presence of lung pulse. So what is the lung pulse? Of course, the lung itself does not generate pulse, but these are transmitted pulsations from the cardiac pulsation into the lungs, which could be reflected on the lung tissue. And when you put the M mode to see the seashore sign is here, when you look at the sandy structure of the lung below the pleural line, you will typically see the intermittent pulsation of the lung with every heartbeat. This is important. Why this is important? Because it also rules out pneumothorax. So to summarize the causes of loss of sliding, you will have pneumothorax as the most famous and important cause, but you will also have loss of ventilation of the lung. For example, if you have a right-sided mainstem intubation of the lung, so you will have no ventilation of the left side. If you have massive atelectasis, extensive pleural fibrosis and adhesions, and patients with cardiorespiratory arrest, and also patients with no ventilation. For example, patient coming with COVID-19 ARDS, put on veno-venous ECMO, so we are not ventilating these patients to give the lung opportunity to rest, then you would not expect to see sliding in the lungs because they are not ventilated. And on this 2D image here, you could see clearly that there is no sliding at the pleural line. You might see a little bit of sliding at the lateral part of the image here, and the area in between sliding and no sliding could be referred as the lung point, which is the transition zone between sliding and no sliding. And this is an example of a patient who has no sliding on the right side. So we scan the lungs at 2 points anteriorly on the right side, at 2 points posteriorly on the right side. And you can see here absence of sliding on the right side and preserved sliding on the left side. And you could also start to see different type of artifacts from the one that we just saw, which is laser-like beams, vertical-like comet tails extending from the pleural line down to the far field. What are these artifacts? We will discuss this very shortly together. So if I lose the lung sliding, and when I suspect pneumothorax, I want to confirm that there is no sliding, because sometimes I might not be able to see sliding. So I have to confirm with M mode. And if I don't see sliding, but I put M mode and I still see the seashore sign, I would be assured that there is no pneumothorax. But if I don't see sliding and put M mode and see this picture, then I would be very suspicious of pneumothorax. And this confirmed the absence of sliding. So you see the difference here. We almost lost the sandy structure of the lung parenchyma, and you have almost a mirror-shaped reflection of these continuous lines of the chest wall all through the lung. This is called the barcode or the stratosphere sign. It could be one of the signs in pneumothorax. And these are different signs of pneumothorax put together by Giovanni Volpicelli to give us high accuracy in diagnosing or ruling out pneumothorax. So when you have the presence of A lines, the absence of B lines, the what we just mentioned briefly and we will discuss very shortly, the absence of lung sliding, the absence of lung pulse, and the presence of lung point, all these together give you a more closer and accurate diagnosis of pneumothorax. So what is the lung point? As we mentioned, it is the transition zone between the presence of sliding and the absence of sliding on the lungs. And you can also confirm the presence of lung point by whenever you see the loss of sliding at the zone, so you confirm it by M mode and you see the barcode sign. And when you slide back to the area of sliding while the M mode is running, you will start to see the sandy structure again of the lung parenchyma. And this is a confirmation of the lung point. And why the lung point is important? So besides to confirming the diagnosis of pneumothorax, it is the most specific sign for diagnosis of pneumothorax among all these signs that I mentioned. It can also be used to monitor the progression of pneumothorax. So when your lung point is very lateral, you would expect to have a big pneumothorax. And when the lung points start to migrate more anteriorly, you would expect that the pneumothorax is resolving and getting reduced. So we've mentioned very briefly about the B lines. So we finished the A lines. Now let's go to the B lines. What are the B lines? Don't confuse it from the Curly's B lines that we used to study in our practice in the chest X-ray analysis. These are different, although both can be present in heart failure, but the B lines describe the presence of vertical-like comet tails, laser-like beams, and there are criteria to tell that you have B lines. They have to be extending from the pleura itself down to the far field, so they should not be short. They should reach down to the far field to fulfill a diagnosis of B lines. They have to be moving with the lung sliding, which is a very important feature, and they typically erase the A lines when they increase. So simply this is a reflection of loss of aeration of the lung. So you start to see B lines when you have an increase in the extravascular lung water, which give us the diagnosis of the interstitial syndrome. So what are the main causes of interstitial syndrome? It can be either cardiogenic or non-cardiogenic pulmonary edema. So the question now, can I see B lines in cardiogenic pulmonary edema and non-cardiogenic pulmonary edema? The answer is yes. Then you need to understand how to differentiate both categories, how to differentiate heart failure from ARDS, because in both conditions, you will be able to see B lines. And this is another example of B lines. And again, when I got these B lines, I have to use the low frequency transducer, whether the cardiac or the curvilinear probe. Again, you will see the B lines extending from the pleural line all the way until the far field. And you will see them moving with respiration. And you can also detect the amount of extravascular lung water by looking at the degree of B lines. So in the B lines, when they start initially, they are isolated in number. And when you have non-confluent B lines, which are plenty of B lines, but they are not fused or confluent together, this could reflect a degree of interstitial edema. But when the B lines become extensive and becoming fused together like a curtain, then you would expect a degree of alveolar edema. And this is very important to assess your patient severity. And this is an example of curtain-like B lines in a patient with congestive heart failure. You look at the pleural line here, it is very thin and healthy, and the B lines are quite plenty to the degree that they are all combined or fused together and they are confluent. They are making a curtain-like structure moving together with breathing. And these are the different applications of the utilization of B lines in heart failure diagnosis, monitoring, therapy titration, risk stratification and prognosis. It can also be used in monitoring patients on dialysis, assess the degree of volume overload, and of course, in our COVID-19 category of patients, B lines are very important to assess the degree of loss of aeration of the lungs. And it can also be utilized in patients with interstitial lung disease. And here we come to the different grades of the interstitial syndrome, starting from the first grade, the best grade of aeration, where you will have A lines, so the lung will be black. And when you start to see B lines, but they are not severe enough, they are not confluent together, you have the black and white pattern, which reflect a degree of interstitial edema, which is moderate. And when the B lines become very confluent, like the one we just saw together, and they become like a curtain, it makes the lung looks white in structure, which is a degree of alveolar edema, and the worst degree of aeration is the presence of consolidation. And this is an example of different degrees and different numbers of B lines. So we have also to put in consideration that we can have normally up to 2 B lines in one intercostal space. So 3 or more B lines in one intercostal space is considered abnormal. So the ones at the 3 at the top of the screen are considered normal, and the 3 at the bottom of the screen are considered abnormal. And Luna Gargani, in her paper, quantified the number of B lines if the full screen is white to be estimated around 10 B lines. And now comes the £1 million question, as we may say. How do I differentiate between cardiogenic pulmonary edema and ARDS? This is very important for intensivists, for cardiologists, for emergency physicians, for internists. You want to know whether your patient has B lines due to cardiogenic or non-cardiogenic pulmonary edema. So what are the criteria for differentiation by lung ultrasound? To get the diagnosis of ARDS, you need to specifically look at the pleura with the high-frequency probe, the linear probe, to see the pleura, the health of the pleura. So the normal pleura is thin and healthy, like this, and this is a patient with hydrostatic pulmonary edema due to heart failure, but this is a patient with non-cardiogenic pulmonary edema due to pneumonia, and you can see clearly the difference between this pleura and that pleura. This pleura is quite thick, irregular, and you have subpleural consolidation, these hypodensity interrupting the pleura itself. These are specific for pneumonia, and these are quite important in our cohort of COVID-19 patients that we are all facing and seeing at the moment around the world. Why? Because COVID-19 has shown us that it is more of a peripheral disease. So the pleura is likely to be involved. So you will more likely to see the subpleural consolidation frequently in patients with COVID-19 pneumonia. And also look at the thickness of the pleura itself. The pleura will be thickened, irregular, and shaggy in non-cardiogenic pulmonary edema due to pneumonia, but it will be very thin and healthy, as I said, in cardiogenic pulmonary edema. The second item of differentiation is looking at the distribution of B lines. In hydrostatic pulmonary edema, specifically the B lines will be symmetrical, bilateral, and more at the bases of the lungs. But in ARDS, the B line distribution is always asymmetrical and non-uniform, and you typically have areas of spared lung. So you will have areas of A lines, and in between them you will have areas of B lines. This is very important to get into the diagnosis of ARDS due to pneumonia by lung ultrasound. And this is an example of the subpleural consolidation. Again, I use the high frequency probe to get this, to look clearly into the pleural line in high definition, while on the other hand, when I use the low frequency probe, I saw the pleura very thin and healthy, and these are curtain-like B lines. The other important thing to look at when you are differentiating ARDS from cardiogenic pulmonary edema is looking at the costophrenic angles by your low frequency probe with the indicator to the patient's head first, as we said. What you would expect to see in ARDS, you would expect to see consolidation. And consolidation is defined as the lung is transformed into tissue-like structure. So on the screen here we have This is the right side. We have the liver, we have the diaphragm as our landmark, and above the diaphragm you don't normally see this tissue-like structure. If you see this, you are definitely sure that this is a consolidation. And why do I say consolidation? Because you have very heterogeneous hyper and hypo densities with multiple air bronchograms inside this area of hepatization, as we can call it. And also you have some degree of pleural effusion, which is this dark fluid around the consolidation. While in isolated cardiogenic pulmonary edema, you will purely see pleural effusion without evidence of consolidation. But don't forget that you could get an overlap of both conditions together. And this is an important example of or an important summary of the differences between cardiogenic pulmonary edema and ARDS. As we said earlier, in cardiogenic pulmonary edema, you will have homogeneous distribution of B lines bilaterally. The pleura will be regular and thin, and you might get a small pleural effusion, while in ARDS, you will have typically inhomogeneous distribution of the B lines, pleural thickening irregularities, subpleural consolidation, spared areas, and you would get posterior consolidation as well. This is another example of consolidation. We have the spleen on the left side here. We have the diaphragm, and above the spleen, you get this tissue-like structure with multiple air bronchograms. And these are also different examples of consolidation on both right and left sides. And typically here you see the air moving inside the bronchi with every breath. This is a dynamic air bronchogram, and this is specific for patients with consolidation, especially due to pneumonia. On the other hand, if you see static bronchogram, which is not moving like this one, it is more likely favoring atelectasis, which is another important great feature of lung ultrasound to differentiate between consolidation and atelectasis. One other thing you could utilize clinically to differentiate consolidation from atelectasis is to look at the homogeneity of the tissue itself, the hepatized tissue. As we said, the consolidation due to pneumonia is more likely to be heterogeneous like this, but if you see it more likely homogeneous in one part, this is most likely a degree of atelectasis due to a large amount of pleural effusion, which is causing compression of this part of the lung, which is labeled as compressive atelectasis. And it's typical to see this in patients with large amount of pleural effusion, and it can cause what they describe as the jellyfish sign, where they have large pleural effusion compressing the lower lobe of the lung, causing what is looking like a jellyfish, an area of the lung moving or floating inside the large bag of fluid. And here we come to an important utilization of the lung ultrasound in such category of patients, especially when we manage ARDS due to COVID-19. So we mentioned in one of the previous slides about the different grades of aeration. Some authors also started to analyze the degree of aeration and put them together into a scoring system to try to get a quantitative assessment of the degree of VQ mismatch on both the right and left lung. So as we said earlier, this is an important paper by Bohemad et al. And he said he quantified the degree of aeration from 0 to 3. 0 is the best aeration and 3 is the worst aeration. So if you see A lines with no B lines or up to 2 B lines, as we said, you would give it a score of 0. If you see multiple B lines, but they are non-confluent, so they are not enough to be fused together, not causing a curtain, this is taking a score of 1 point. If you see confluent B lines making a curtain-like structure, this takes a score of 2. And if you see complete loss of aeration in the presence of consolidation, this takes a score of 3. So with this scoring, you would get a worst degree of aeration of 18 scores on the right lung and 18 scores on the left. And why this is important? Because when I get patients with COVID-19 presented with ARDS due to pneumonia to the intensive care, I can apply this scoring system by scanning each of the 6 lung zones on the right and the left, and then I get number, and then I can monitor the progression of the aeration by repeating the lung ultrasound and getting an idea how the scoring will progress. So as long as the lung is recovering, you will see a downward trend of this scoring and reduction of the number, which reflects an improvement in aeration. And these are other different causes of compressive atelectasis with the typical jellyfish sign. So here comes the importance of protocols. So there are several protocols which utilized the use of lung ultrasound to manage patients in the emergency and intensive care settings. So when we have a patient presented with acute shortness of breath and hypotension, one of the important protocols described is the blue protocol, which is bedside lung ultrasound in emergency. So when I utilize lung ultrasound to get to the most probable diagnosis of this acute deterioration, the first thing I look at is lung sliding by looking at the upper and lower blue points according to this picture here. So I scan the upper and lower blue points on the right and left and see if there is sliding or not. If I see sliding, then I see if there is B profile or not. Are there B lines or not? If I see B lines, which is named as the B profile, then I would consider the possibility of pulmonary edema. And if I see A lines, I need to check the deep veins. Is there an evidence of DVT? If the answer is yes, I consider diagnosis of pulmonary embolism. If there's no evidence of DVT, I move to the stage 3 of the blue protocol, which is looking at the posterior and or lateral alveolar and or pleural syndrome, labeled as the PLAPS. And this is our PLAPS point. So how to get here? From the lowest blue point, I move laterally along the axilla until the posterior axillary line and looking for any evidence of consolidation or pleural effusion. To put it simple, if I see any evidence of consolidation or pleural effusion, which is confirming the presence of PLAPS, and then I can confirm or get a possibility of diagnosis of pneumonia. If I don't see any abnormality at the PLAPS point, then I would probably get a possibility of diagnosis of COPD or asthma. So this is all if I get sliding. What if I don't see sliding, if I lose the sliding? Then I check again if there is a B profile or not. If there is a B profile, I consider diagnosis of pneumonia because, as we said earlier, extensive pneumonia could be associated with pleural fibrosis and you might lose the sliding with this. But if there is an A profile with loss of the sliding, then I have to suspect the presence of pneumothorax. And I would confirm the presence of pneumothorax if I see a lung point. And if I don't see a lung point, I need to consider other diagnostic modalities. Lung ultrasound is not enough. So what if I get a combination of A or B profile, meaning that sometimes I see A profile on one lung and B profile on the other lung, meaning A lines on one lung and B lines on the other lung, or I see consolidation. This is getting me to diagnosis of pneumonia. All right, so this is the blue protocol. The other important protocol is the false protocol, which is fluid administration limited by lung ultrasound. I find it quite useful, and it's important to rule out the presence of different types of shock. You can rule out the presence of obstructive shock or cardiogenic shock or hypovolemic shock, and it can also detect distributive shock. And I find it useful to limit the amount of fluids I administer to my patients. So for example, when I initially scan my patient lungs and I see A lines, A profile, and I start to give fluids in a patient with hypovolemia or sepsis, then I start to see the presence of B lines, neo B lines. Then could be an indication for me to stop giving the fluids. And this can be happening early on before the patient start to show clinical signs of pulmonary congestion. So at the end, I would recommend using all the tools we have in ultrasound and echocardiography to have an integrated approach. I would scan the neck veins, scan the lungs, scan the pleura, looking for any pleural effusion, scan the IVC, and of course, scan the heart. So if we have multiple tools together in an integrative manner, I would probably get the best idea about what's happening to the patient. And with this integrative approach, you can have different scenarios. For example, your patient is having hyperdynamic left ventricle, small right ventricle, flat or very thin inferior vena cava and multiple A lines and no signs of B lines or no signs of interstitial edema, you would likely consider hypovolemia and giving fluid. But in another scenario, if you have your patient with hyperdynamic left ventricle, for example, a bit of dilated right ventricle, dilated IVC, and the presence of lung point, you would then consider the presence of pneumothorax. Patient with severely dilated, depressed left ventricular systolic function with dilated IVC and wetness of the lungs demonstrated by the presence of B lines and pleural effusion, you would consider heart failure and hydrostatic pulmonary edema. And your other patient could be having RV strain, dilated, reduced function of the right ventricle, dilated IVC, the presence of A lines, and deep vein thrombosis. Then you would consider pulmonary embolism. And finally, with the advent of the COVID-19 pandemic, which is currently, unfortunately, hitting across the globe, several centers in the world started to actively utilize lung ultrasound. And this is one of the important triage protocols which was developed in Spain in one of the hospitals. And they started to consider lung ultrasound to triage patients and decide whether they will be admitted to the hospital, they will be managed at home, or they will require admission to the intensive care, or they will be ruled out from a diagnosis of pneumonia based on the pattern of abnormalities. So according to this protocol, A pattern with dry lung and normal lung, they will ruled out from having pneumonia. And patients with B lines who are not having desaturation and normal oxygen level and non-confluent B lines could be managed at home, provided they are stable, while patients with reduced oxygen saturation, confluent B lines reflecting alveolar edema will be admitted to the hospital and managed inside the hospital. And of course, severe degree of drop in oxygen saturation and the presence of consolidation, these are the category of patient that will definitely be admitted to the intensive care unit. Of course, this protocol is not based on evidence, and we need to do further studies on that to validate it. But I think it's a beginning for stronger utilization of lung ultrasound in acute emergency situations, especially in managing patients with ARDS. And this is a useful data set developed recently by the Intensive Care Society to categorize and consider the different management protocols for patients with COVID-19, pneumonia, and ARDS by looking at several points of the lungs, placing your linear probe at 2 points anteriorly bilaterally across the chest, and place your curvilinear probe at the PLAPS point posteriorly and looking for any abnormalities. If there's no abnormality found, you don't need any intervention. But if you see B lines or consolidation, then you will consider which pattern is predominant. If you have diffuse B lines, this could trigger you to possibly consider giving more PEEP to your patient to recruit the lungs. And if you see evidence of consolidation or atelectasis, that would consider you to think of providing proning for your patient to help opening up the recruit the atelectatic lung units. And it's also important to assess the progress of lung aeration, as we said before, by assessing the development of the different profiles, A profile, B profile, and C profile. And finally, this is another useful infographic developed also recently by the Intensive Care Society of the UK, which gives you simple and brief information about the utilization of lung ultrasound in patients with COVID-19. And this is an interesting study which was very recently published by the Chinese Critical Care Ultrasound Study Group. And they tried to correlate between the lung CT scan findings to the lung ultrasound findings. And there was actually a good correlation, although of course the study involved few number of patients, and we need further larger studies on a larger number of patients to validate these findings. But this is, I think, an important and stronger involvement of the lung ultrasound in such situations. So I will finish by take-home messages. As we just saw together, lung ultrasound is a useful tool in COVID-19 diagnosis and management. It should be an integral part of our daily ultrasound and echo study in acute settings, whether in intensive care, emergency, cardiology. B-lines can be used reliably for monitoring treatment of heart failure patients. I would always call for an integrated approach when we assess and manage our patients. We have to always be mindful with wearing the personal protective equipment when we manage these patients to make sure that we are safe, and look after the equipments and make sure the equipments are cleaned and disinfected thoroughly after use to prevent and reduce the instance of cross-infection between patients. And of course, it is always important to put in consideration the role of accreditation and quality control of every diagnostic tool we are using to make sure that we are doing the right thing at the right time. And my final message to you is stay strong and safe. Thank you.